It says live and there's a timer up at the top. Live 13, 14, 15, 16, 17, 18. Okay, because if it's not, we're going to be pissed.
Hey, bud, can you log into ProMedTec one? Either just shoot me a text, either y'all got there and go. Yep, ProMedTec one. All right, man. Cool. Bye. Another one of those two.
I know, I don't even know that they're so freaking good.
Well, I have to cut out around 9:30. I've got a meeting.
Okay.
School. Cool. Did you get signed in? Oh, no, that's it. Good morning.
Yeah, no. I'm fixing to send you the link, I think. All right. So just give me a minute. I'm going to text it to you.
Plan's still the same for tomorrow.
All right. I just sent it to you. Can I send this link to whoever's over in Imboden so they can look at it? Okay. Morning, Dr. Deel. How are you, sir?
I'm great. Moving slow.
Yes, sir? Okay. I'm going to. Okie doke. Thank you. Bye. Hey, Chris, can you shut that door down there?
big wet paint.
No.
You'll get out here.
Hey, JT, did you ever like hard for like sedation and made those other things?
I made a rough protocol for the Versed infusion. I wanted to double check with you before I started on the ketamine because initially it was 0.1 milligrams a kilogram. That it was the same as the Versed, and I wanted to double check and make sure that wasn't the correct dose.
That's a perfect starting dose.
Okay.
Ready?
Are we set up on that, Bobby?
Trying. Give me just a second. I'm trying to send out the.
Hey, did John mention to you approving national?
I thought I did.
Oh, okay.
I get emails every so often. I thought your name was on there. I did 4 like this week.
Okay. Well, I haven't looked in the last couple of days. I'll double check real quick. Because my name doesn't say Mandy on there.
I'll look again.
I'll
Anyway, I
look
mean,
real
I can do it
quick.
right here. It's just, they send me emails whenever I need anything approved.
Okay.
I know I did like 4 this week. So. Is it approved?
I don't know yet, but it takes a to get over. Pending skill, nope.
Okay. Maybe it was just on the Arkansas website.
Yeah,
I think I saw your name. That's why I was thinking that I did.
I haven't even done Arkansas yet. I'm waiting on my national. I can send that one in because it's easier just to send for national court to state.
Literally like, this is done. How do I get my power? It doesn't help me much.
It should.
So was it even challenging for you to know your instructor? So, have they put in the new testing yet with the choose all but apply? Has that started yet? Skippy's
Right. I sent the link to it.
Okay, I'll text you.
I think it would make it easier from the past, but what a while. You gotta change the nursing plan, but it's gotta change. It's now, it's all short answers and fill in the blank.
You ready? All right, guys. Lots and lots of info this morning. It's gonna be a fascinating month. Bringing out RSI. So, objectives there, of course. All right. So first off, what is RSI? It is the virtually simultaneous administration of an induction agent and a paralytic. Different than giving small incremental doses of something like Versed until someone relaxes enough that you can intubate them. This is when you basically push one in as fast as you can, change the syringe, push the other one in, flush it, and then proceed with intubation. We use a very hefty dose. We don't titrate. We use a dose anticipated to actually induce general anesthesia. In fact, that's what induction agents are. Whenever you're about to have your appendix out, we give you a dose of propofol or etomidate, and then we put the gas on. When we were overseas, we actually operated with propofol drips. And so those are the doses that we're talking about here. You can actually perform surgery on the doses that we use. The neuromuscular blocking agent, is one of the keys to it. It's one of the things that markedly improves success rate. So, why do we do it? It makes it easier and safer and increases the success rate.
You should be able to get.
That's the key. You have the highest success of a first pass intubation attempt with an experienced provider when you use rapid sequence intubation. Also prevents aspiration. That actually is why it was invented, with a way of protecting the airway. In traditional RSI, you do not ventilate the patient once you give medicine, which is fine because this was designed for an operating room setting, which you can go 4 to 8 minutes before we have to worry about hypoxia. That's traditional RSI. But even as it's modified in an emergent setting, it still helps to prevent aspiration. The way that it makes it easier, more successful, is because it eliminates the normal protective airway reflexes. That also decreases the trauma. If you've ever had to fight with someone who has a bit of a gag and you're trying to get that tube down, you're going to end up doing trauma to the airway. And then, of course, for the patient's point of view, they don't remember it, and so they like it better as well. What are the risks? Hypoxia and a failed airway, of course. 1 in 100 will end up being a failed airway. And then hypotension, which is by far the biggest complication. You should anticipate it every time that you use RSI.
So is that just fluid boluses, doc, or is that?
So it's a mixed bag, and we'll get into that with the doses. But whenever you do RSI, expect hypotension. There's really no way to avoid in both systemic vascular resistance and even with ketamine, which has the least. So who do we intubate? Can't oxygenate, can't ventilate, and expected unstable course. This again is no different than anything else. It's probably the first paragraph in the first chapter of the ER text. Who do you not consider doing RSI? Remember, when we administer an induction agent and a paralytic, you are quite literally betting the patient's life that you're going to get this intubation. That's exactly what you're doing. And so these are little mnemonics. There's 48 apps that you can use, it doesn't matter which one, to predict whether it's going to be difficult to bag them, whether it's difficult to use direct laryngoscopy, whether it's going to be difficult to use an extraglottic device such as an LMA or a King airway, and then whether it's going to be a difficult or impossible cricothyroidotomy. So as you're looking at these, that's when you need to decide, is this going to be a difficult intubation? And if it fails, can I use a bag valve mask, an LMA, or a cric? Sometimes there's going to be just a predicted course that none of these are going to be very easy. I always think that, I want you to particularly note the last one. I always think that cricothyroidotomy is a salvage maneuver and something that will always work. There's a lot of times when you cannot do a cricothyroidotomy, you just can't. Neck radiation, you have distorted anatomy, you're just not going to be able to. What are your alternatives? Open your airway. Always go back to your BLS, OPA and NPA. You can do delayed sequence intubation. Now, what is delayed sequence intubation? This is a term coined by Scott Weingart, but what is it? You guys familiar with that at all? All right. So the name is not descriptive, which is why I don't like it. But this is using non-invasive positive pressure ventilation with a half-dose ketamine. The goal here is to, remember, BiPAP will correct pulmonary edema from congestive heart failure or acute exacerbation of COPD. If we can keep them on BiPAP for 12 hours, they're not going to need intubated. If you can just put them on BiPAP in the back of the truck, they're not going to need intubated. The problem with BiPAP is that they don't like it. And so if you can give them a half-dose ketamine and then let them watch the unicorns, then that's it. You don't need to proceed any farther. So that does two things. One, it prevents the risk of an intubation, and two, you actually treat the problem. Like I said, the treatment for pulmonary edema is BiPAP. It works better than anything else. It works better than Lasix. It works better than anything else. Acute exacerbation with COPD, as long as you don't have bronchospasm, that's still going to be the cure for you. You're going to get rid of the CO2. Mental status is going to improve, and you won't need to put them on a ventilator. You can always assist respirations with bag valve mask. Again, you guys know this just from your EMT courses. If it's a medication issue, consider naloxone or flumazenil, and then of course nasal intubation. This is your general checklist that you're going to have prior to doing it. You're going to pre-oxygenate 3 minutes on 15 liters per minute. If they're hypoxic, then you're going to need to use positive pressure ventilation. That's just through a bag valve mask. And if they are hypoxic, you're going to need a PEEP valve. What does PEEP do? Remember this from the non-invasive lecture?
Maintains alveolar recruitment.
Exactly. So the PEEP is going to improve their oxygenation. If you don't have a PEEP valve, it's very easy to do it. You just put your hand over the exhaust port on the bag. Are you going to get it exactly 5? No. Does it matter? No. But that's a perfectly valid way of bagging. You got to have a good mask seal, but that will give PEEP. 3 minutes is what it takes to 100% just flush out the lungs. They talk about 8 full tidal volume breaths. That's not going to happen in somebody that you're going to need to intubate, but that's the alternative. The reason that I mentioned 8 full tidal volume breaths is that if this patient is breathing, it takes 8 breaths for them to go back to where they were before you put the supplemental oxygen on. So keep that in mind. You have a non-rebreather on for 3 minutes, you pull it off for 8 breaths while you're doing something, and now you've just lost your 3 minutes of pre-oxygenation. Next is your equipment. SOAP-Me is a fine mnemonic. It doesn't matter which one you use. Suction, oxygen, of course.
Does that see the screen?
Not very well.
Your airway equipment. You're going to have a dual setup. So the first thing that you're going to do is you're going to have your blades, one above, one below. You know what you think you're going to need, and then maybe one less. You're going to need 2 sides of the VT2, your boost, your stylet. The second part of your dual setup is your rescue devices, your LMA, your King Vision, or whatever you guys use, one of your combi tubes, and a cric kit. It's all going to be there, ready to grab, just there. Your pharmacologic agents, you're going to have those drawn up and ready pre-treatment. There's a couple of reasons why they mostly apply to pediatrics. Certain things such as atropine and lidocaine are listed as options. They really haven't been shown to have any benefit. Your induction agent, your paralytic agent, what you're going to do to keep them paralyzed, and then again, fluids and vasopressors ready, because no matter what, as soon as you intubate people, the sheer mechanical action of increasing intrathoracic pressure decreases preload, which then decreases cardiac output. All the medicines will decrease systemic vascular resistance and decrease cardiac output. There's no way you're not going to decrease cardiac output by intubating somebody. So if they're barely hanging on, and now we've intubated them, they're going to go hypovolemic, and they're going to have cardiovascular collapse. So just expect lower blood pressure, lower cardiac output as soon as you intubate somebody. That's just going to happen. Have your fluids and vasoconstrictors ready. Then, of course, you're going to need your monitoring equipment. End-tidal CO2 is your key. SpO2 monitor, ECG, and blood pressures, of course. The team, you really can't do this with a single person. The guy who's holding the laryngoscope and the tube in his other hand is going to be just like a surgeon. He's got that view, and he's just going to ask for something, and the partner's just going to have to just reach it over. And so everything has to be laid out, and the partner has to know exactly what he's asking for. So clear communications, closed circuit communications, just like you say. And then have a plan if you fail. Bag valve mask, digital intubation, LMA, video laryngoscope, or cric. Questions? So again, this is your checklist. You have all that ready before we start. These are the thought processes that you guys are going to get into. First thing, this is just general how all these different algorithms relate. Overall viewpoint, so let's get with the main one. All right. Patient needs intubation. Can't oxygenate, can't ventilate, expected unstable course. First question, is this patient dead or dying? Pretty easy. If they are, then we'll go to the crash airway algorithm. And we'll take a look at that in just a moment. If they're not dead or dying, then we go through our lemons, our moans, Roman, all the ones, and to predict whether or not this is going to be a difficult airway or not. If it is, if we do predict a difficult airway, then we're going to go to the difficult airway rhythm. If it's not, then we can go ahead and proceed with RSI. We attempt. If we're successful, that's great. If we're not, then we look, are we still okay with our oxygen? If we're still okay with our oxygen, then we go ahead and we try up to 3 times by an experienced provider. If not, then we go to failed airway. If our first attempt is unsuccessful and we can't maintain oxygenation, then we go to the failed airway. Questions on that? This is the main one. All right. Crash airway. Again, this is a patient that's dead or dying. Pretty easy. So do your best to maintain oxygenation as you get your stuff ready, and then try to intubate. Are you successful? If yes, great. If not, is your oxygen still adequate? If it's not, then we go to basically going to be a recurrent theme. If you can't maintain oxygenation, we go immediately to the failed airway. One of the biggest problems is not moving to the failed airway and keeping on the same pathway that we're on. If during a crash airway, meaning someone who is unresponsive and you're really forced to act, you don't get the tube the first time for whatever reason, but they still have SATs that are acceptable, then we administer a slightly higher dose of succinylcholine. This is the only time that you're going to see administering succinylcholine without an induction agent. Why? Because they're already unresponsive. So we don't need to put them to sleep. They're already asleep. But by completely suppressing those gag reflexes, just like we said before, this will sometimes facilitate a difficult intubation. And it's higher than the standard dose of succinylcholine because we need to do it now because, again, this is a crash airway. Instead of the usual 1.5 mg per kg, we go with 2. Then we'll try again after that. Then it kind of follows with the main airway. Are you successful? Yes, great. Post-intubation management. If not, you look at the oxygen sats. As soon as the oxygen saturation is dropped, then we go to the failed airway algorithm. Any questions on that? Again, this is for somebody who is dead or dying.
So the 2 on the subs is
That's higher than
just
usual.
for crash airways.
Exactly.
JP, we got to change that in the
To
protocol.
1.5.
1.5 for everybody is. Now I don't mind
Because our protocol says 2 right now, just RSI. So we need to change it to 1.5 and then drop it back down to, or increase it to 2 for crash.
Yes. The reason, so the reason at the lower dose is, again, to avoid the post-intubation hypotension. It's the doses that matter. And so we've started lowering our doses so that we have less of the hypotension and the cardiovascular collapse afterwards. And so that's why it's moved down a little bit. Difficult airway. So we do whatever, and we realize this is going to be a difficult bag gum mask, a difficult direct laryngoscopy. What's it say there? What's the first thing that you do?
Get help.
Call for help. Call for a more experienced provider. There's nothing wrong with having 2 experienced providers in the back of the truck. Because, again, this is going to be a difficult one. Sometimes, though, you're forced to act. And so that's where the next little thing comes from. If you cannot maintain oxygenation, you got to do something. Okay, then you're forced to act. This is almost the same as the crash airway. It's just this patient is rapidly decompensating. You're not going to be able to get anybody else there in case it doesn't work. And so in this case, our goal is to do our single best attempt. And so get the most experienced provider that you got in the back of the truck, give the RSI drugs, try it. You get 1 shot. If it doesn't work, you go straight to failed airway. Questions on that? If you're not forced to act and you can wait on the help to get there, then we keep monitoring oxygenation. What do we happen again if we can't maintain oxygenation? We go immediately to filled airway. Again, it's a recurring theme. The biggest problems that we see for EMS crews having problems with rapid sequence intubation is not going to that filled airway. Anyway, so if we are maintaining oxygenation, then we look what is likely to work. Bag valve mask, LMA, what's probably going to work. If it looks like intubation is going to be successful, then you do the RSI with a double setup. That's what I was talking about earlier. From my point of view, you should always have a double setup because sometimes the predictions just don't work. That way you've got your secondary devices ready. So you've got your everything all set up according to that basic setup checklist that we said, with your rescue devices, including your LMA, ready to do the digital innovation, ready to do a PRIC in case it fails. If it doesn't look like you're going to be able to bag this person or an LMA get down for whatever reason, consider nasal intubation. Consider something else. Consider, whatever else you can. Again, at some point you may be back into the forced to act scenario, and that's fine. We go back up, we get RSI drugs, we do one successful attempt. If it doesn't work, you go straight to the filled airway. Notice a key difference here. Someone who is predicted to have a very difficult airway, single best attempt, if it doesn't work, you go to filled airway. Someone who is not predicted to have a very difficult airway, up to 3 attempts as long as you're maintaining oxygenation. Make sense? All right. All patients need pre-oxygenation. PEEP valve on the bag valve mask if they're hypoxic, monitor breather if they're not.
All of our BVMs have built-in PEEP valves now from the last ones that I've ordered, and we'll continue.
Sweet. During the procedure, you're going to put a nasal cannula on and run it at 15 liters per minute the entire time. That will actually cause enough diffusion down into the lungs that you can go up to 30 minutes in a normal person without going hypoxic, even if they're not breathing. The same as the old transtrach jet insufflation, the 15 liters by nasal cannula does exactly the same thing. Start your resuscitation before intubation. Go ahead and start pressors and fluids if there's any concern. Again, we know we're going to have some degree of decreased cardiac output whenever we intubate. You have a very high risk of death if you combine acidosis and hypoxia. Those are the two biggest issues. All meds can cause hypotension and cardiovascular collapse. The dosage is the most important factor. That's what I was saying. We're trying to go a little bit lower on our doses when possible, because that's what does it. Ketamine probably has the lowest risk. Etomidate is probably just as safe. They did some really interesting head-to-head comparisons, and they were literally neck and neck. But all of them had episodes of hypotension. Propofol, of course, certainly has. Versed certainly has. So the individual drugs. Etomidate, it is probably a GABA agonist. Mechanism is not exactly for sure. 0.3 mg per kg is your standard listed dose. You can decrease that. 20 to 30 is the dose that you're going to use for most people. Onset 30 to 60 seconds, and last, we always say 8. Onset 1 minute, last 8 minutes. And again, there's your range. There are case reports of trismus and laryngospasm. It's kind of interesting. You'll give the drug and literally they won't be able to open their mouth. The case reports, it's not a problem because you're going to give succinylcholine. As soon as that takes effect, then you don't have to worry about it. Just be aware that it can't, that you give etomidate and they suddenly start clenching their jaw, that's fine. That's why we're giving such at the same time. Possibly long-term adrenal suppression. Some people will tell you not to do that with septic shock. It's never been proven to be an issue, but you may read that periodically. Ketamine. 2 mg per kg plus minus. Again, there's ranges for all of these. The higher the dose, the more likely you're going to have ill effects. The higher dose, the more likely you're going to have cardiovascular collapse. It is an NMDA antagonist. That has a couple of interesting effects. One, it means that it is not affected by flumazenil. So that's not, you do not have a reversal agent for ketamine. Onset's 30 seconds, lasts 20 minutes. It is a sialagogue. So you have to remember you're going to have increased secretions if you use this one. Not an issue for most of the time. It is possibly a problem with burns because they already have a bunch of airway edema and secretions. And then, of course, they will have emergence reactions. Again, not a huge deal that you guys are going to see, but as they start to wake up, sometimes the hallucinations follow them into the waking world. Succinylcholine, 1.5 mg per kg. So this is a depolarizing neuromuscular blockading agent. Onset 45 to 60 seconds, lasts 5 to 10 minutes. They talk about hyperkalemia. You're really not going to encounter anyone in which this is going to be an issue in the acute setting. If you look at all the reasons, the contraindications, these are always such as burns that happened 2 weeks ago and things like that. And so, like I said, for an immediate trauma, for an immediate airway collapse, you really don't have to worry about hyperkalemia. But again, there's 8, you can look at the reasons, the contraindications. The key to these things is if you intubate someone for seizures, and that's you could imagine a situation in which you just have intractable seizures or hypoxic and you want airway protection. That's conceivable. Suck stops them twitching, but it does not stop the seizures. The brain damage continues. So you have to be aware of that. This did not solve the problem. It just masked it. The other problem, of course, is that they can't move, although sometimes people can be awake. Look at the difference in onset. Succinylcholine lasts slightly longer than etomidate, so they may wake up and not move, and it's a terrifying effect. So we have to keep that in mind. Rocuranum and those drugs last significantly longer. So what if it doesn't work? All right, immediately call for assistance. Can you maintain oxygen? No? All right, you gotta do something about it. If you have a failure to maintain oxygenation, you go straight to a chronic. However, a bridging device can be used while you're getting ready to cut. Don't delay cutting, but it's perfectly reasonable to say, all right, let's shove a king airway or an LMA down to see if it works while I'm getting my knife out. Does that make sense? If you went to failed airway, but strangely enough, you are able to bag them or something and keep their oxygen up, then you can try other things. Try your video laryngoscope, try your LMA, and then see if you can do it that way. But as soon as they drop their oxygen and you can't get it back up by any of your means, get ready to cut their throat. Use a bridging device like an LMA or a king. Questions? Again, don't hesitate to cut. LMA, consider digital intubation. That's an option as well. There have been 2 or 3 that we just managed to salvage real quick just by digital intubation. Post-intubation management. Secure the tube and verify placement. That's easy enough. Repeat your primary survey. Why do we do that? Because the drugs and intubation cause cardiovascular collapse. We got to make sure that we still have a heartbeat. Continuous end-tidal CO2 monitoring. Continue the resuscitation that you began before intubation, right? If you start it now, you're going to be behind the curve. And then analgesia sedation. Fentanyl, ketamine, and Versed are usually the drugs that we're going to use. Fentanyl is preferred first, followed by ketamine, followed by Versed as far as sedation for ventilated patients. So let's talk about our drugs. Fentanyl boluses are preferred rather than a continuous infusion. Fentanyl on long term has some really weird effects. To the point that you get hyperalgesia. They actually start hurting more when it's on a bolus. They do some weird things, and so just when it's on a drip. So PRN boluses work better. Ketamine infusion, that's the range. And so we were talking to JD about evening out the numbers based upon, because I don't know what kind of vials you have, what's 1,000 milligram of what, so I just stuck that there.
500s.
Again, so that he's going to have a nice card, put this much in this much of a bag and run it at this rate, with a 60 drop set, just to take the math out. Just keep in mind there's a range up to around 0.4 mg per kg per hour. Propofol, same thing, half mg per kg per hour with a maximum around 3. Versed, you can use it as an adjunct to any of those. They all work fine together. Versed and propofol work on the same receptors, so you're not going to gain much benefit if they're on a propofol drip and you give them a dose of Versed. You're hitting the same receptor, so it's not going to help you. But if you're using fentanyl and ketamine, again, those work on different receptors. You got the opioid receptors, you got the NMDA receptors, and then you can use Versed to work on the GABA receptors, and you're hitting all three. And so you will gain benefit if you give an additional dose of Versed when you're using one of the other agents. You don't gain any benefit by adding Versed to propofol. There's a range for the infusion. Keep in mind that there's a dose of milligram IV push, and it's micrograms per kilogram per hour when we talk about an infusion. If we need to change the math, we can change it to all milligrams. So then what do we do? How do we set up our vent? So most patients are going to use a lung protection strategy. This is the RSI protocol card. For most folks, we want assist control. Why?
They're not breathing on their own.
Well, let me rephrase. Assist control as opposed to IMV.
Because assist control won't deliver any extra breath and increase their.
So assist control makes sure that every breath is a full breath. They can breathe over it just fine. This will allow them to self-correct their pH. Remember, hypoxia and acidosis are the two things that we're trying to fight. One of the easiest ways of correcting acidosis is to let them breathe as much as they want and blow off as much CO2 as they want. Folks who have respiratory problems, your little nursing home ladies that don't have strong respiratory muscles, people who have been breathing and about to fatigue, they don't have the strength to blow off the extra CO2 on IMV. That's why we put on assist control, because they don't need strength of the respiratory muscles in their diaphragm to blow off extra CO2 on assist control. The machine does almost all the work for them. All they have to do is just, if you know those SCBAs that the firefighters use, how as soon as you start inhaling, so they start blowing the air, that's what assist control does. The difference being, once you start the flow, you're going to get that full 600 mLs whether you want it or not. Now the patient may not like it, but I don't care if they don't like it, because it's going to allow, they will vary their respiratory rate as they need to get rid of that CO2 and correct the acidosis. Again, hypoxia, acidosis are the two biggest enemies. On assist control, as long as they have 10 minutes after you've intubated, they will self-correct their pH. That's why if you notice that post-vent management, we don't mention succinylcholine, because if we do that, then we have to adjust and correct their pH. As long as they're not paralyzed, they will correct their own pH on assist control. A young, healthy person who you intubated simply for trauma can self-correct their pH on IMV. But that's just because they have good, strong respiratory muscles. Anyone who doesn't, who you don't think has the ability, because of the diaphragmatic weakness, because of overall weakness, because of their fatigue, they will not self-correct their pH on IMV, which is why we start with assist control. We use a lower tidal volume. Again, this is the lung protection strategy. And it's ideal body weight. Any of your med calcs, they make little wheels and paper charts and various little things to figure out what their ideal body weight is. This is based upon sex and height. In general, start with a respiratory rate of 18. We assume that we need a slightly higher respiratory rate because anyone who is not breathing well is going to have buildup of CO2, so they're going to be acidotic. And then you've got your FiO2 and PEEP settings. They are adjusted in tandem according to this chart. Our goal, of course, is to get their SpO2 somewhere around 88 to 92. That's fine. You can go higher if you need to, but I mean, once we get to that point, we're good. So the way that you look at this is, so you start them on maybe 50% FiO2 with a PEEP of 8, right? And you're still not where you need to be as far as oxygenation. They're 82. So what's your next step?
Get a 0.5 and then a PEEP of 10.
Yeah, so you keep the FiO2 the same. You don't actually increase it. You go up to the PEEP of 10. Then if we're still not there, then we increase the FiO2 a little bit. And so you just follow it along this card. For people who you know have congestive heart failure, pulmonary edema, and of course, COVID now, we use the higher PEEP strategies. And so look at those. Those are some reasonably high numbers as far as PEEP goes, or at least they look high. But think about it. I mean, your typical inspiratory pressure during the inhalation phase of a vent is around 45. So we're really only doing about half of what the pressure that goes in. So low PEEP for most people, high PEEP for known pulmonary edema, congestive heart failure, and COVID. Titrate the oxygen. Prolonged hyperoxia scars the lungs. That's why we don't want to do it. Once we intubate somebody, see if they can tolerate an FiO2 of 40% and then start turning up the PEEP. Again, follow that card. Oxygen saturation 88 to 95, 88 to 92, somewhere in like that. You don't have to get 100. You don't even have to get 99. If you go 95, that's perfectly acceptable. And again, use the RSI PEEP table to adjust both FiO2 and the PEEP. Then we titrate ventilation, otherwise known as minute volume. Most of the time, this is going to be with respiratory rate, but you can adjust the tidal volume as well. This is what gets the CO2 down. We want a CO2 of 35 to 45, especially in head injuries. That's your ITLS guidelines. We want a CO2 of 40. So if the only way of getting rid of CO2 is increasing minute volume, you can do that by taking deeper breaths, or you can do that by breathing faster. Keep in mind, though, COPD folks who have pretty bad airway obstructions, you might have to tolerate a higher CO2. And that's okay because they're used to it. They're used to the lower pH. Otherwise, you end up with breath sacking, which has significant hemodynamic consequences far in excess of tolerating an acidosis or hypercarbia. So keep that in mind with our COPDers. Permissive hypercapnia is one of the phrases we use. Then check your pressures. And you guys actually have like a printout of the little up and down graphs
On the of your waveform ethnography.
Yeah, some of that looks like that. You have that on your vents?
Yes.
Okay.
Well, we have it on the monitor.
No, we have it on the vent.
It's on vent.
It would be on the vent.
It's on that little screen.
It's not the
there.
capnography, it's
It shows
the
waveform.
waveform for the pressures.
Yeah.
Every vent should have it. I mean, they have the very, very old oxygen powered ventilators that have no electronics. They don't, but I mean, everyone that has a battery should. All right. So then we go to peak and plateau pressures. Peak pressure tells you how much resistance there is to inflating the lungs. The most common, of course, is a kinked tube. You kink the tube, the peak pressure is going to go up, not the plateau pressure. So then we got mucus. Do you need to suction the tube? Is the tube kinked? Did you just choose a really small size and now we're trying to breathe through a straw? Those are reasons why the peak pressures might go up. Usually, or is the patient coughing? Is the patient morbidly obese and you need higher pressure, something like that? The peak pressures we watch and we try to figure out why they're high, but it's the plateau pressures that's the issue. The plateau pressures are the pressures that the lungs, the individual alveoli are seeing, and that's what's going to damage the lung. Peak pressures you have to ask for. The vent's just not going to the peak pressures are always there. The plateau pressures you have to ask for. There's a button on every vent.
Guys, ours is the manual.
Oh, look, it even says plateau pressure.
Yeah.
The point being, you have to push it before it will show you the plateau pressures.
You got to push ours and hold it. because if you just push it, it's just going to deliver a breath and let you. So push it and hold it, and everything will come up on the screen.
Each vent's a little different, but no vent is going to give you a plateau pressure unless you ask for it. There's a button on there somewhere. And then, and that, of course, and the reason that you have to do that is because it stops the breath momentarily. And so that's why you got to push and hold it. It's that you can't just push it and then have the thing stop working. So what it does is it will inflate the lungs to whatever settings you had, and then it holds it there, and it puts a tire gauge on, and it shows you the readout. That's quite literally what it does. We want to target less than 30 if possible. If your plateau pressures are too high, it is usually because the tidal volume is too high. So you just lower those down. Sometimes you can play with the settings like inspiratory time and things like that, but mostly if the plateau pressures are too high, if they're greater than 30, then you're going to cause lung damage. So let's lower the tidal volume, increase the respiratory rate, keep the minute volume the same. Waveforms. So again, you got to do all this. You got oxygenation, ventilation, pressures, and waveforms. So when you look at waveforms, the primary reason that we do that is to avoid breath stacking. There's other reasons. You can do inverse ratio ventilations, altered IDE ratios. That's not important. You may see it, ignore it. We want to make sure we're not breath stacking. So if you ever see somebody who is just a chronic lunger, they can get out a fair bit of air within the first 1 second. And then after that, this is prolonged expiration. There's no way you can speed that up. You can jump on the chest, you can do whatever. Ventilators so far cannot suck air out of their lungs. So we have to rely on them to push the air out of their lungs. And a lot of times it takes them a while. So what happens if we put in 400 mLs of air, and then they're doing their slow 2-second exhale, and then we give them another breath before that 2-second exhale is done? Exactly. So now, instead of 400 in the lungs, they got 420, and 440, 460. And eventually, even though it's not technically a tension pneumothorax, it looks exactly like a tension pneumothorax. Because it basically is. We're just putting way too much air in these lungs. To fix that, immediately is pretty easy. What do?
You can
Unhook the
detach
tube.
and
And they go, because again, it sounds just like a pneumothorax. But as soon as you put the ventilator back on, it's going to happen again. So we got to know what to do.
You can change your IDE, but on our vents, you get more bang for your buck changing your rate than your IDE.
Exactly. Respiratory rate is going to be your primary thing to avoid breath stacking. And again, it goes back to what we said earlier. For extended transport times, you can play with your IDE ratio. If you're just coming to a local hospital, change your respiratory rate, tolerate a higher CO2 to avoid the breath stacking. This is what your waveforms look like. So the air goes in, and then air goes out. So what's supposed to happen is it goes back to 0. If for whatever reason they have severe COPD, that line never goes back to 0. That means we still have some residual air that we pumped in there that hasn't fully left. So each time they're going to get more and more volume in that lung until it finally just explodes. Actually, they'll go to cardiovascular collapse before it explodes, but either way, it's not a good thing. So this is the key that you're going to look for on your waveform. Is does the exhalation phase go back to 0? If it does not, and they have severe COPD, then we need to space out our breath to give them time to fully exhale. Okay. Sometimes they worsen. So that's where our doped mnemonic comes in. And it's fairly straightforward. The first thing that you do, the dopes is a nice mnemonic, but literally the first thing that you do is you unhook the vent and you put them on a bag. That takes care of your equipment. What do you do then? You try to squeeze the bag. Does the air go in? All right, good. So it's not an obstructed ET tube. Then you put your ears on the patient. When we squeeze, do we have equal bilateral breath sounds? If we do, all right, the tube is not displaced. Then we go down, and that also tells us about pneumothorax and bronchospasm. Now you're not going to know, and then if we see fluid coming up, frothy stuff in the tube, then we suspect pulmonary edema. You're not going to know about a pulmonary embolus, but you can get bronchospasm